and select your most preferred language. Vincent, please explain in French.
Bonjour et bienvenue à tous pour cette conférence de presse. Vous pouvez choisir votre langue préférée pour suivre cette conférence de presse en cliquant sur le globe en bas à droite de votre écran et en choisissant le français. Over to you, Dr. Mary.
Merci beaucoup, Vincent. And now joining us all the way from Kampala in Uganda is Dr. Mashidisho Moeti, the WHO Regional Director for Africa, who is currently on mission in Uganda. This is a hybrid presser, so we will be having journalists in the room with Dr. Moeti, also asking in-person questions as we take the online journalists. I will now hand over to Dr. Moeti to introduce our other panelists. Good morning and welcome, Dr. Moeti.
Good afternoon in Kampala, Mary, and good day, bonjour, and welcome to all the journalists attending this press conference today. As Mary said, I'm joining you from Kampala in Uganda, where I'm wrapping up a 3-day mission to observe the country's commendable response to the current Ebola outbreak. Along with providing an update on WHO's heightened efforts to support Uganda, I'll also discuss 2 other growing health threats on the African continent: diabetes and antimicrobial resistance. I'm very pleased to be joined by Lieutenant Colonel Dr. Henry Kyobe Bosa, the Uganda Ministry of Health Incident Commander for the Ebola outbreak. A very warm welcome, and thank you for making the time to be with us today. I'm also joined up here by the WHO representatives, Dr. Jonas Tegegn, who has been, of course, leading our team in our support to the response. So let me begin by commending Uganda's leadership, the President, His Excellency General Yoweri Museveni, the Honorable Minister of Health, Dr. Jane Ruth Acheng, and very importantly, the people and communities in Uganda, along with the health workers and authorities and key partners for a robust government-led response. However, since the outbreak was first declared on the 20th of September, the Sudan Ebola virus has now been detected in a 9th district, this one with a large urban population. Because cities favor the spread of the virus with their highly mobile residents and often crowded living and working environments, the confirmation of new cases in Jinja, following cases in Kampala and Masaka, demands that we push even harder to get ahead of the threat and reach zero fast. To date, there have been a total of 141 confirmed and 22 probable Ebola infections in Uganda, and 55 confirmed and 22 probable deaths. WHO in the African region has deployed 80 experts to support the fast-paced response and assisted Ugandan health authorities to deploy a further 150, including 60 epidemiologists. We've also helped train nearly 1,000 health workers and village health team members in contact tracing, and another 1,155 health workers in infection prevention and control in health facilities. 15,000 units of personal protective equipment, or PPE, were delivered to protect health workers caring for patients. Most unfortunately, 19 health workers have already been infected, and tragically, 7 of them have died. We as partners all need to expand and intensify our support to the response so that we bring this outbreak to an end. And as such, the expected arrival of vaccine candidate doses next week in Uganda is welcome news indeed. WHO's Committee of External Experts have approved these candidate vaccines for inclusion in the planned clinical trial, the start of which marks a pivotal progression towards the development of the first vaccine against Sudan Ebola virus. A separate group of experts has also selected 2 potential therapeutics for trial, and a trial design is now being submitted for approval by WHO and the Ugandan authorities. Meanwhile, Dedicated response teams are putting in incredible efforts on the front lines to safeguard communities. I was privileged to speak to some of these yesterday. It's encouraging that the outbreak is slowing in 6 districts, with 2 reporting no cases in more than 42 days. But we cannot afford to become complacent, and this robust support needs to be maintained. Communities also need to embrace the critical control measures to ensure everyone is working together to end this outbreak. WHO has launched an $88.2 million appeal to fund the response in Uganda and to support Ebola readiness in neighboring countries. Unfortunately, only 20% of these funds have so far been received. We plead that time is of the essence. Meanwhile, member states continue to grapple with a range of other health threats, 2 of which were the subject of dedicated International Health Days this month. The first is diabetes, which currently affects about 24 million people in the African region, but is projected to rise by almost 130% to 55 million in the next 2 decades. Yet, just fewer than half of all affected people are aware of their status, the highest deficit worldwide. Associated death rates are also 10 percentage points higher than the global average, according to new WHO analysis. Compounding the threat is that only half of everyone living with type 1 diabetes, the most common form of the disease amongst children, have access to the insulin that is critical to their survival. To halt the progress of this silent killer on our continent, increased access to diabetes diagnosis, treatment, and care is critical. The August 2022 endorsement by African health ministers of a WHO-led initiative called the PEN Plus marked an important step forward. As WHO, we commit our full support to member states' actions to institute the requisite measures, including making essential medicines, technologies, and diagnostics available and accessible at district hospitals. I'll turn now to World Antimicrobial Awareness Week, which starts tomorrow, and which aims to raise awareness of the risks posed by the overuse and misuse of antimicrobials, including antibiotics. Antimicrobial resistance, or AMR as it is known more commonly as drug resistance, occurs when disease-causing germs become resistant to traditional medication, that is antibiotics. This makes infections harder to treat and increases the risk of disease spread, severe illness, and death. Sub-Saharan Africa carries the heaviest burden globally of resistant bacterial infections, which were responsible for nearly 5 million deaths worldwide in 2019, more than HIV, AIDS, and malaria combined. Since more than half of all deaths in the WHO African region are caused by infectious diseases that we manage with antimicrobial medicines, it's become clear that AMR endangers decades of advance towards the control of health threats such as malaria, tuberculosis, typhoid, cholera, meningitis, and gonorrhea, among others. The excessive unnecessary use of antibiotics in humans and in food animals, which is one of the main drivers of AMR, needs to be urgently addressed. I want to take this opportunity today to issue a call to action to African governments to avert a potential catastrophe by prioritizing investment in AMR strategies with a One Health approach, a vital currency for effective AMR implementation. Fundamentally, countries need to strengthen infection prevention and control measures and improve surveillance of antimicrobial resistant infections. The appropriate use and disposal of medicines needs to be promoted and regulated, supported by community education on the depth of the negative consequences of antimicrobial resistance. It's imperative that we work to maintain the critical balance between addressing AMR while preserving access to life-saving antibiotic medicines. I'll now hand over to our guest before taking questions to the media. Thank you very much for having joined us again, and over to you.
Thank you so much, Dr. Moet. First, thank you so much for coming around to Uganda to support us. We appreciate WHO's support to this response from the very beginning up to where we are. In addition to WHO support, we thank the support of other partners as a country. Since the declaration of the outbreak on the 20th, after confirmation of the outbreak on the 19th in a male individual in Mubende district. Since then, as Dr. Moet said, we have had 141 confirmed cases and 22 probable cases. And so far, we've lost 55 individuals and 76 have been discharged and have been healed. Of note, this is not the first outbreak in Uganda, actually the sixth, and this is the fourth of Sudan Ebola virus. And we've had significant experience and expertise in this. But what we do know is that each Ebola outbreak is different, and we have to use different techniques to be able to respond to them. And each outbreak comes with different challenges, which we are battling with. As we know, it took only just a week to have the outbreak coming out of the epicenter into the city. And as Dr. Mawet earlier said, it has moved to another big city, and we have had secondary transmission. And that poses another challenge, which we are battling with. But with the community with us, as we have seen the epicenter districts of Mubende and Kasanda, we think we should be able to come on top of this. And knowing that when the population appreciates and understands the danger before them, we are able to move very fast. Of course, we appreciate the complexities in the urban settings, as we've seen in Kampala, where one case generates several contacts that we have to follow up. And this is something that we are watching. We do know that the restriction of movements in the two districts has slowed down the transmission or the importation of cases outside the original epicenter districts. But that's not all. We need to continue working and make sure that we bring this outbreak to a speedy end. Thank you so much.
Thank you very much, Dr. Moeti and Lieutenant Colonel Dr. Henry Bosa. And we have heard from all our panelists right now. So it's your time, journalists, to ask your own questions. To do this, you can use the Q&A function on the Zoom platform. Tell us your name and the name of the media organization you represent. And for those in the room, you can raise your hands and Elise will get to you to have your question asked. We have additional experts that are on hand to answer your questions. First, we have Dr. Jonas Tege, who is the WHO representative in Uganda. We have Dr. Anna Maria, a medical officer in WHO Geneva. She's responsible for research and vaccines. We have Dr. Patrick Otim, who is the Ebola outbreak incident manager. Dr. Walter Fuller, technical officer for antimicrobial resistance. And lastly, we have Dr. Sheikh Diallo, who is a technical officer for strategic information. I will start with Paul, who is ready to ask his question. Paul, are you there?
Yes, I'm there. I'm here. Thank you very much for the opportunity. My first question goes to the research lead at the WHO. We would like to have information about the vaccine candidates and what are the hopes and what is the outlook and what insights can you give us about the clinical trial? And I also want to commend the Uganda team responding to the outbreak. And information came out. I saw something on social media yesterday that suggests that there could still be issues regarding getting people to adhere to the guidance in considering those that still want to carry out burial rituals for their relatives that died of this. So I want to know how you are dealing with this, over contending with religious beliefs in your efforts to control the pandemic. Thank you very much, and well done on your response.
Okay, thank you, Paul. So the first part of your question will be taken by Dr. Anna Maria, and then the second part of your question will be taken by Lieutenant Colonel Dr. Henry Kobe, and the WR could also complement. Thank you.
Thank you very much. Good afternoon. So the first thing I would like to say is that WHO wants to recognize and commend the leadership of the Ministry of Health and of the Makerere University, where our principal investigator is located. Thanks to their leadership and hard work in the past 4 weeks, the teams are now ready to start the vaccine trial up to international standards, and this really has to be recognized. The second is that, as we announced yesterday, we have an independent expert committee that we call it the Vaccine Prioritization Working Group. This committee reviewed the evidence provided by the 3 developers of the vaccines being considered and recommended that the 3 candidate vaccines should be in the trial. These vaccines are 2 vaccines that use an adenovirus as the means of transport and presenting the virus protein to the immune system. One is called the CHA3, is the adenovirus 3 that has been developed by the Sabin Vaccine Institute with support from the United States of America government via an agency called BARDA. The second vaccine is the ChAdOx1, that is a similar vaccine using an adenovirus being developed by the University of Oxford, the Jenner Institute, with support from the United Kingdom government and being manufactured by the Serum Institute of India. That's the first 2 vaccines. The third vaccine is what we call a vesicular stomatitis virus vaccine. This virus that is harmless to humans is used to transport the protein of the Ebola virus, also that induces immune response. This vaccine has been developed initially by Merck, but now is being sponsored by IAVI, the International AIDS Vaccine Institute in the United States, and they also have support from the United States government via BARDA. So we have 3 vaccines for which we have data from preclinical data, so it means studies in the laboratory and in animals, and for 2 of them we have already some safety information that suggests that they will induce an immune response, and also that they have chances of being efficacious. The other thing that I want to say is that these platforms are not new to us. The BSV platform is the same one that is used for the Zaire Ebola virus, and about 350,000 people have been vaccinated in Africa thanks to the courageous efforts of the researchers in the DRC, in Sierra Leone, and in Guinea. And the adenovirus vaccines have been extensively used, the ChAdOx1, for the COVID vaccines. And for the CHA3, it was used in thousands of people in clinical trials back in the day of the 2014-16 epidemic. So we don't know if we don't have direct evidence that these vaccines induce protection in humans. This is why WHO is working with the government of Uganda and the Makerere University to conduct this trial. But the choice of the vaccines is based on the best data available to our independent experts. Thank you.
Thank you very much, Dr. Anna Maria. And then Dr. Henry, please.
Thank you so much, Paul, for the question. It is true we've had variations in adherence to SOPs at the beginning, but we are seeing this progressively changing. And I think you're referring to that incident where one individual was actually exhumed, leading to a relatively big cluster of infections. This has not since happened again, and we think it will not happen again. But we also need to understand that the population at the beginning, this index of suspicion or appreciation of Ebola was low, and this has progressively changed over time. And we learned that the adherence to SOPs or adherence to the guidance that is given by the Ministry of Health took a bit of time, but now where we are, where initially we had a lot of family level transmission and also facility level transmission, this has since changed. Initially, we saw several individuals moving from one facility to the other. This is progressively changing. Initially, we had individuals moving to traditional healers. We are seeing less and less of this. And for example, most of the cases that we've seen in Kampala, people actually report early and we have good clinical outcomes. And of course, noting that the adherence to SOPs, that's why we're seeing that the force of infection in the 2 epicenter districts has actually come down. As Dr. Moet earlier said, that we are having fewer and fewer cases coming from the epicenter. And the only major worry that we have is the current extension of the outbreak in a major city, which are closely following. Thank you.
Thank you, Dr. Henry. Dr. Jonas, do you want to weigh in on this?
Yeah, I think only one point. As you know, with Ebola, the disease starts in the community, and it's very important to have a full engagement of the community and creating the risk awareness and bring all community leaders on board so that we have the adherence as well as the preventive aspect from the community. I think that our biggest tool should be risk communication and community engagement. And that's an area which we haven't seen much investment from our partners. And we would like our partners, donors, to make resources available to address this issue. Thank you.
Thank you, Dr. Jonas. And next, I'll go to Anne Soy from BBC. Are you ready to ask your question?
Yes, I am. Thank you very much for the opportunity. My question will mainly go to WHO. There have been questions asked about the completeness of the data that we're being given from Uganda. And these concerns are coming from experts, some of them on the front line. Are you concerned from where you sit that there are cases that could be missed, that are being missed in the community, as we saw with the woman who traveled to Masaka, for instance? She was lost to follow-up, and then she sparked an outbreak there, and then we recently had Ginger. Does the response team or does the response have a grip on this outbreak? And secondly, on the 25th of this month, schools will close and children will be traveling all over the country to go back home. The school closure has been brought forward. Are you concerned about what that might portend in the midst of an outbreak?
Thank you, Anne. I'll start with you, Dr. Jonas, and Dr. Moeti could weigh in.
And Henry would also help us. I am comfortable that we have as much access to the data as we need. Could we get more data by doing more investment in contact tracing, in more case investigation? Yes. And also we are seeing that the response is at a good level. All the things which should happen are happening. The issue is if we want, in this time of real-time social media, people expect all the information to be available on day 1 or on day 0. Maybe we haven't reached that, but as we go on, I see that we are getting access, not only access, getting and investigating that data as much as we need to. I don't believe any of my team are impaired in doing their job from lack of data, because data entry is done with partners in the room. When this data is entered into the system or when case is investigated, WHO people and other partners like CDC are in the room. So I am not very much concerned about that. Could we get more data? Could we share more data? Always, yes. We would like to get more data. We would like to share more data and consolidate those data, verify that data. But that is, in a more ideal situation, probably we want every data to be available to us, which for the sake of this outbreak, all the data we need is available, and we are part of the investigation, and we are part of the people collecting those data. It's a matter of time. As for the closure of school, it's preponing the vacation time, and I think the ministry have presented a credible argument, and probably Dr. Henry Chobe could clarify on that. We find it to be advancing it by a week or two would not affect the effect on children because the safety is important as well. Thank you.
Thank you so much, Phoebe, for the question. Maybe I need to start with the fact that the lady, the pregnant mother, 22-year-old who moved to Masaka, over 14 days, we've not had any secondary transmission coming from Masaka. So that has to be very clear. That much as the lady moved there, and including all that the work we are doing there, we've not had any secondary transmission coming through. We've not had any secondary transmission coming through. On the issue of data and the sources of data, some excited responders in the field may actually send out data. And the good thing with Ebola is one, if at any rate as a country were hiding any data, the evidence would be out, and we'll be seeing people dying in mass. And we'll be seeing most of these people turning up at health facilities. So if anyone says, and the good thing, like Gabriela said, we do process this data, the access to information, both primary data and analyzed and semi-analyzed data, actually is shared by every partner. And we work together at all levels of the response, right from the tactical level through the highest level. And we share this information. But what happens sometimes, we have specific reporting times. If we do have a reporting time as 2200 hours, and then we have our next reporting time 2200 hours, for any data that may come after, then we will report it in the subsequent reporting. And that creates confusion and excitement among some people who are in the field, indicating that we're hiding data. For the lady that actually who went to Masaka, our findings are not that we missed her. We think she had an exposure in a facility where one individual actually had been treated in Kampala. We never hid this information. And we think we shall continue to share as much information and all the information available as it comes through. On the earlier closure of schools, one of the things is that we don't have diffuse transmission of Ebola in this country. And we think for now, schools are relatively safe. So even when we let children go back home, we don't think that we shall create a dispersal effect and spread the disease across the country. That would be different if we had diffuse transmission coming from many places, and that would cause a much bigger risk. And if that was the case, we could have planned for that in a different way. But again, going back to the issue of data and information, as a country, we share information as much as possible with all partners. We work together from the lowest level to the highest level of the response. And we shall continue doing so. And we have no reason whatsoever as a country on why we should deny anyone data or hide information. But of course, understandably, outbreaks are very complex, and understandably in the urban settings, that the listing of contacts is a very complex issue, which we are coming to terms to. But as much as possible, we do that. But the other thing that I want to explain around it is that cases going out of one place to the other is one thing, but the most important thing is how fast we get them. And this is what we have done, and we shall continue doing by enhancing surveillance across the country, by making sure that we have a very rapid turnaround time of results so that we process these results and these patients on time, and have those that have been identified beyond the epicenter districts in time so that we limit further spread. Thank you.
Thank you very much, Dr. Henry, for that elaborate response, and Dr. Jonas. Dr. Moeti, do you want to weigh in on this?
Thanks. Yeah, just very briefly. I mean, just to reiterate that our experts, especially of late, first of all, to say that we had a team that's embedded, working closely with the Ministry of Health team that's been looking at the data. So those colleagues have had access to the data from the beginning. We now have additional colleagues who are able to access the raw data, meaning to look at the original data and to be able to advise further. And these are some senior colleagues at the regional and global levels, so that we see with them what to do with this data, how to use it most advantageously to guide the intervention. So I'd just like to add that we do now have access to the data. I think in terms of people moving around, it was mentioned that the community's understanding, being reassured, accepting some of what needs to be done is a core part of such a response. People will move around. I think that's natural. People will be frightened and be nervous about being restricted. I think some people who may know that they are ill may try to go somewhere else. I think that's something that we expect to happen in an outbreak. What we need to be clear about is what we are doing to understand, not only to be saying things to people, but to understand some of their own concerns, their fears, their beliefs, so that we anticipate this in adjusting our interventions. We make sure that the people who are relaying the messages is not just officials, but it's people that they actually believe and trust. So they do unusual things and allow themselves to be exposed, if you like, or restricted to help us all in the response. I think what's very important is the strength of our contact right down to the community level with our health facilities to be able to track and follow people who move around, and the communication with people. So I think there's some things we know that will happen. We anticipate this will happen. We don't expect everybody to 100% listen to everything we ask from the start. That's why we have a response, but we're very encouraged by the way that this is evolving now, while accepting that the risk in a big city like Kampala is really quite heightened, and we are making sure that we are scaling up the capacity to respond appropriately for this circumstance. Thank you.
Thank you very much, Dr. Moeti. And then I turn to you, Elise. Please take questions from journalists in the room.
Yeah, Mary, we already have 3 questions from journalists. Let's start with the gentleman in front of me.
Yes, thank you so much. My name is Vincent Silico. I work with Radio 1 in Kampala. I have first 2 questions going to Dr. Moeti about the antimicrobial resistance concept we put forward. We talked about it in the context that it's a heat problem that is escalating over there as the days go by. But since your acknowledgement of this, I don't know what strategic recommendations or interventions you're putting forward as an entity responsible on this continent, the African continent, to see that the governments therein go by or abide by, to see that these things come. Because in all reports, we're seeing that people are eating poison and that in a way, from the medications and everything. The other is about, yes, President Museveni was addressing the nation a couple of days ago, and they said if people refuse to declare themselves, he's considering reporting, establishing an interstate kind of arrangement where they report so and so is a contact with Ebola and everything. I didn't liaison with him on this point. Do you agree with him, this kind of approach, given the respect of so many other health confidentiality and so many other concerns? Then to Dr. Cho, when you say that we have passed the family transmission, and then you said we had a family transmission stage, we had facility transmission kind of state, and now we are seeing pockets in the major towns. Could you give us where Uganda stands now in terms of the Ebola status? If someone say, like, are we community infection stage? Where are we right now? If someone asks that question. Dr. Wadmire, you always talk about resources. Could you quantify this? And finally, it's about the vaccine narrative. We have seen the vaccines being deployed in the DRC in the recent past. We don't want to allow or reject that narrative, but then the magnitude of the problem is we only lost 55 people by now. I'm not saying only because they are few, but 55 in the context of other epidemics that we've seen. What warrants the vaccine initiative rather than treating these cases and getting done with them?
Thank you so much. I think these questions, we have 3 questions actually, not one only. And we will start with, we have 3 parts. The first on the resource mobilized by WHO, if we can quantify that. This question will go to Dr. Jonas. We have the question on the vaccines going to Anna Maria, and the question on COVID going to Dr. Kyobe.
I think she's done. You've missed out on.
You missed out on AMR.
AMR. Okay, I'll start.
Maybe
I'll start on the AMR.
Yeah.
Okay. Okay, thank you for your question on antimicrobial resistance. You can't hear? Are you fine? Can you hear me now?
Yes.
Okay, great. That's fine. So thanks for the question about antimicrobial resistance and what is it that WHO is doing. I mean, we have a program on antimicrobial resistance, which has been intensified over the past few years with resources being provided by one country to make sure that we accelerate the work that's been done actually at the global level. So one of the most important things is to raise the awareness of governments so that they provide the policy environment in which actions can be taken by different groups around protecting the efficacy of the antibiotics that we have. Because the key issue is that if we use antibiotics widely in certain ways, we drive the emergence of resistance in the microorganisms to these medicines. First, in addition to working with governments, helping them develop a plan and framework for what they are going to be doing, it's very important to raise the awareness of the medical fraternity. So those people that prescribe antibiotics, because we know that there is an excessive use of antibiotics for infections that don't actually need antibiotics. So one of the issues is to raise the awareness about prescription practices and the use of antibiotics by the medical fraternity so that you only prescribe an antibiotic when it's actually needed. Secondly, raise the awareness of the public about the fact that if you have a viral infection like a flu, you actually don't need an antibiotic. You will get better without using an antibiotic. We need also to work with the pharmacists so that people can't just come walk in and buy an antibiotic over the counter without a prescription. So we need to work with different sections of the medical system. We need to work with the medical councils that regulate the practice so that they, and the medical associations, so that we persuade, train, remind the professionals about the need to be careful about the use of antibiotics, because the disaster is that if antibiotic resistance bacteria emerge, for example, they can sweep through a population and we will not have a tool to use to control an infection among the infections that I listed earlier on. And then the other thing is that the excessive use of antibiotics for animals then leaks into the storage systems, can leak into the water systems where people have to use water which is not processed and purified, and that drives further the emergence of organisms that are resistant to antibiotics. So there's a whole range of actions within the national policies, with the medical fraternity, with the public, with the pharmacists. We need to make sure that you can't just walk into a market and buy an antibiotic without having a prescription, which is something that is a problem in our countries. And then very importantly as well, need to work with the testing of the quality of medicines so that we don't get what are called fake medicines of poor quality being sold. And you think as a doctor, you're prescribing a good antibiotic to a patient and they're getting something which is substandard. So all of that is part of the action that needs to be taken to preserve the effectiveness of antibiotics and to minimize the further emergence of antimicrobial resistance.
Thank you, Dr. Moeti. Maybe let me go next and answer the issue of the resources. As you would recall, the time we prepared this budget or this plan, we only had 3 affected districts. Since we have seen the increase in districts and the fact that now it involves 2 major cities, maybe we can even count it at 3 if we can count Masaka as well as a major city. The scenario changed. But also, if you look into some of the plans were looking at 6 months time, while others were only 3 months. There is also a difference in that. Currently, following the accountability meeting between partners and the government, one of the things we agreed is to have one plan where we will consolidate all these requirements. As for what I said, we need to require more resources for risk communication and community engagement. Is in that area, we haven't seen a major funding. Maybe you might have heard that UNICEF was saying that they were not having sufficient funding as they required to look into that. But others also areas were considered they were not fully funded. So that's what I meant, that we may need the investment of donors to put more fundings available. And as the scenario changes, we will keep you informed. And also when the plan comes out, we'll make it public.
I didn't understand the question. Sorry, just before we move off this, colleague, you asked the second question about interstate agreements. I didn't quite grasp your question, if you can repeat it.
I beg your pardon on that. It wasn't an agreement per se, but our president is Mr. Uganda, and during his state of address on Ebola last a couple of days ago, Tuesday, he said that maybe as government, they're seeing a lot of resistance to declare. People don't want to declare themselves to the health authorities, and some tend to move out of this country. Our country might be attempted to move out, and they are planning to select the areas with the states, interstate, to conduct an interstate arrangement where patients are maybe declared on a kind of dashboard. They are seen so that they are known, so that wherever they go, they can track them. So I just want to share your opinion on that, on whether it's really in the standard practice of your health standards. It's a question.
Okay. So I'll let my neighbor start on that question.
Yes.
And then
Yes,
I can complete on that.
last then Dr. Moeti can be on that. Your first question was where are we as a country, and as I said at the beginning, that the major drivers of transmission so far that we know are actually transmission within families and then also at facilities. Much as at the beginning we had transmission associated with barriers, this hasn't been so much. But to see where we are, and for Ebola, it is you just need one case. If not well managed, then you reignite everything. So it's very difficult to say we are safe or not safe, not until we have the last case isolated 42 days after, and we don't have any other case coming through. That's when we can say we are actually safe. But what we are not seeing beyond the epicenter districts, we are seeing sporadic cases. This has to be very clear in Kampala. And then subsequently, as we saw, cases moving to Jinja, and they later that moved to Masaka. We have not had secondary transmission. But also in the 2 epicenter districts, as again I said at the beginning, cases, confirmation of cases or infections have actually slowed down. as a result of intense work that has gone on in terms of risk communication, identification of contacts, and being able to follow up these contacts. So on the question of individuals traveling out of the country, what we do have here is that all contacts, and contacts are individuals that have been in touch or who have contacted or with the body fluids, or linen or surfaces, or have been with or cared for the sick ones that have tested positive for Ebola. So all those contacts, we are placed on a no-fly list, and they are not traveling out of the country. And this information is shared on every 3 days with immigration, rather updated every 3 days with immigration, and these individuals are not supposed to travel. The aim of this is to make sure that we don't have Ebola spreading beyond the country. And I think that's what you are referring to in that case.
Okay, I think if I may add a comment, I mean, of course, an Ebola outbreak is an alarming situation. There is no doubt, because Ebola is the disease that it is, and because of some of the experiences that we've had with Ebola. I think that what's very important, in addition to some of the measures, is to help the public to understand. As I said before, help people to understand and reassure people that if you are known to be a case of Ebola, it is for your own good that you access care and treatment. And so the work that we have to do, for example, with people who've recovered from Ebola, is for them to be part of the response in reassuring others that indeed I went through this, like you, I was admitted in a hospital facility, I was looked after in such a way, I have recovered. So I think we need measures that both ensure that restrictions are made, because in fact, the existence of an Ebola outbreak in a country, one that is expanding, could be regarded as an emergency in that country, even if it's not declared as such formally. But we know, looking at the response of surrounding countries, the international response, that it can very soon turn into an emergency where travel from such a country is restricted. So I think it's a very importantly threatening situation in many ways. But one of the most important things, I believe, is to help people to understand that it is for their benefit that they cooperate with the arrangements that have been made in place. And our responsibility is to ensure that when people are admitted in a facility, they are well looked after. The stories that they hear from patients who've recovered is that, you know, your family can come and visit, you have adequate food to eat, you are in a comfortable, reasonably comfortable place. And we help people to be part of the response themselves. I think we need all of this as a set of interventions to get over such an outbreak. Thank you.
Thank you, Dr. Moiti. I think all answers from the room have been, all questions from the room have been answered. Now let's move to Dr. Maria Anne-Marie. She has a question on the vaccine, the narrative around the vaccine and also its safety. Anne-Maria, over to you.
Thank you. I am not so sure I fully understood the entire question. I think that there were three parts to that question. One was about the policy for vaccines, and the other part was about who will get vaccinated. Was it correct?
Yes, the journalist
okay,
is also...
So I just want to first say that the government of Uganda, with the support of WHO and other partners, are doing a great job improving every day the response to the outbreak. And this has resulted in control and interruption of transmission in some of the districts as far as the information we have today. What it says is that with other measures, you can stop outbreaks of Ebola. You can interrupt the transmission. That's the first thing. The second is to mention that vaccines are just a tool that we add to the arsenal of interventions we use to control an outbreak of Ebola. And third, that the vaccines we are evaluating, we are doing the trials precisely because we don't have direct clinical evidence that they actually protect the vaccinated people from Ebola. This is why we are doing the trial. Once we do the trial, if data emerges that one or more of these candidate vaccines is efficacious, there will be an independent expert group in the trial called the Data Safety Monitoring Committee that will review the data and advise WHO and the Ministry of Health as the co-sponsors for the trial on the results and the interpretation of such results. Moving forward, once the efficacy of a given vaccine, one of the three, is established, then there is a process of ensuring the vaccine receives regulatory approval by one or more authorities for commercialization. And in parallel, WHO has a committee that is called the SAGE, the Strategic Advisory Group of Experts, that provides advice and policy recommendations to the countries on the use of various vaccines. In this trial, we are focusing on including in the RINs the people who, on the basis of the data available to all of us, have the highest risk of acquiring Ebola. And this way is the way that we will be able to accumulate evidence faster. This is why this is restricted. Second, we have learned from previous outbreaks that the risk of acquiring Ebola is not equal. So the general population don't have high risk of acquiring Ebola. The contacts of the case, the healthcare workers in contact with the cases are the ones with the highest risk of Ebola. So as Dr. Moeti explained, it is very important that you in the press help us communicate to the population the measures that are recommended to control exposure to Ebola, to the actions that the people who suspect has Ebola has, and then that the contacts collaborate first in the contact tracing and then as part of the trial follow-up if they consent that are included in the trial. Thank you.
Thank you so much, Dr. Anna Marie. And we are moving now to Mary. We have some questions online as well.
Thank you very much, Elise. And now we will go to the online journalists. Ashvin, are you ready to ask your question?
Thank you. Thank you for considering my question. My question is, while climate change adverse impacts can be reduced via immunization, Observer Times question is it necessary to re-engineer vaccines each year to target the strains of disease outbreak considered likely to be prevalent in the upcoming years? Thank you.
Thank you, Ashvin. Dr. Moeti?
Sorry, could you repeat the question? Were you saying the impact of climate change? Can the impact of climate change be reduced by vaccines? Is that the question? Just to be sure.
Ashvin, are you there? Okay, so let me take another.
Hello.
Okay, go ahead.
Yeah, I'm repeating my question. While climate change adverse impacts can be reduced via immunization, Observer Times question is it necessary to re-engineer vaccine each year to target the strains of disease outbreak considered likely to be most prevalent in the upcoming years? Thank you.
Okay.
This is Ana Maria.
I
can try to answer that question, Dr. Moeti.
Yeah, okay. Anna, go ahead.
So this question was raised also during a recent presser with Dr. Tedros, and I will provide a summary of the answer WHO provided at that time. So there are three things. The issues about climate change could expand the contact between humans and some of the virus because the ecosystems may change. But so that's the first one. So in WHO, we have what we call the WHO R&D blueprint for epidemics. And we are now in the process of reviewing the risks that several viruses and bacteria pose has the potential to produce outbreaks and epidemics and pandemics. So we are looking into that. Second, for every one of those identified, we develop what we call roadmaps, that is to identify the research knowledge gaps and then the research priorities. Three, not all the virus and vaccines behave similar. Some of the virus mutate more often than others. We saw that with COVID, but this is not the case for all the viruses for which we have vaccines. And four, influenza is another example of a virus for which every year a new composition of the vaccine is made. And third, the most important thing for us really is to ensure that with the vaccines we have today, all the children, women, and adults who are eligible for vaccination get vaccinated, because that protects lives and reduces transmission for diseases for which we can do that now. Over.
Thank you, Anna Maria, for the response to that question. Dr. Moeti, do you want to add something?
No, I don't believe so. I think she's answered it adequately.
Okay, so let me take this next question from Lucia Blanco. She's from International Spanish News Agency. And this question is coming to Dr. Henry Bosa regarding the Ebola outbreak. Where are the deaths mostly happening right now? In the community or in the health facilities? And what is the proportion? Dr. Henry, please.
Thank you so much. At the beginning of the outbreak, before the outbreak was unmasked, most of the deaths were actually happening in the communities. But since the response, most of the deaths actually are happening in the facilities. So far, we've had 55 deaths among these confirmed cases, and these actually have happened in the facilities. Of note that most of these deaths are individuals who are presented or who we have gotten late that have really turned out to die. But we increasingly see that as individuals come to us as early as possible, they stand a bigger chance of survival. And that's where we have so far 76 individuals recovered and discharged. So to answer your question, at the beginning, deaths were actually happening in the communities, but as of now, case deaths are happening in the facilities and happening majorly among these individuals who are presenting late. Again, as we see in Kampala, where we have good outcomes, where we're getting individuals early, the outcomes have actually been better. Thank you.
Thank you, Dr. Henry. This next question is coming to you, Dr. Anna Maria. And the question is from Bloomberg Fred. When are vaccine trials starting? How many people are targeted? And who is eligible? Dr. Anna Maria, please.
Mary, Dr. Anna Maria might not be available at this particular disconnected. Maybe from what I understood, we could expect the vaccines to arrive next week. And as already explained, the initial targets would be immediate contacts to positive people and health workers who interact with them. And then we'll see after that additional groups will be included. As it stands, with the first batch coming, we would be able to protect all contacts which are appearing. I think there would be sufficient amount from the epidemiology we are seeing. Over.
Thank you very much, Dr. Johannes, for the response to that question. This next question from Rita is coming to you, Dr. Patrick Otim. I would like to know if it is true when one recovers from Ebola that the virus remains in the body for a year, and that if they have sexual intercourse, they can transmit the virus to their partner. Dr. Patrick Otim, please.
Thank you, Dr. Mary, and thanks to Rita for the question. Yes, so research and evidence over the last few years have shown that what we call the viral persistence, that the virus persists in people that have recovered from Ebola. Now, when somebody recovers and is discharged from a treatment center, it is based on 2 negative tests that are done on their blood. So when they are being discharged, they have cleared the virus from their blood and they have been discharged. But during that process of healing and recovery, the virus hides in some particular spots in the body. And one of the places that the virus hides in men is in the testes. So the virus hides in testes. It also hides in what we call the cerebrospinal space, and then sometimes in the eyes. There have been extensive studies to try and identify, for instance, in women, if there is the persistence in breast milk and also persistence in the reproductive tract of the women. So the major risk is with men, where it has been documented that the virus persists in the testes, in semen, for durations ranging from 6 months up to 1 year for some people. So the guidance has been that when a person is discharged from treatment center, there is a survivor program now that has been established in Uganda. For all those that are discharged, they enroll in that survivors program. They are given health education and advised to abstain from sex, at least for the first 6 months. And then thereafter also, if they continue now in the testing program where the semen is tested at least every month until when they get 2 negative tests in the semen. It's also recommended then that they can at least for the first 6 months, if there is to be any sexual intercourse, it has to be protected using a condom, and they are being trained and given this condom and educated on how to use it. So the risk is there. It has been evidenced in the last few years, and we encourage the survivors from the current outbreak to adhere to the guidance and health education that they have been given from the different facilities that they have been enrolled in, and they need to continue to adhere to those first as a protection for their immediate families, but also for protection that they do not start another chain of transmission. So it's a risk that is minimal, but it's a risk that is being managed, and there is best practice and guidance. It's been done in DRC, in Sierra Leone, and in Liberia, and it has been done effectively well. And we'll continue to work with the authorities in Uganda to support the implementation of an effective survivors program for the current batch of survivors that we have. Thank you.
Thank you, Dr. Patrick Oting. We are taking live question from Halimuna. Are you ready to take your question? Okay, so if she's not, okay,
no,
go
I am.
ahead.
Okay, thank you very much. Hi, my name is Halima Athmani. I correspond for Voice of America. And my question is about the vaccination. We are talking about ring vaccination or upon the arrival of the vaccines. Considering our past history, especially if you compare it with COVID-19 vaccinations and how in the beginning it was all about, showing Ugandans that this vaccination is needed. So the target again was health workers. There was a lot of vaccine hesitancy by the health workers themselves. And since this vaccine is actually still on trial, what guarantee do we have that those health workers who are going to be vaccinated with this Ebola trial vaccine are going to be okay with it? Otherwise, I think the feeling is, Ugandans are being turned into guinea pigs every time there's a new vaccine. Thank you.
Thank you, Halima. Dr. Jonas, can I start with you?
Thank you, Mary, and thank you, Halima. First of all, we could learn from our experience in the Ebola vaccine in Uganda itself. What we have realized is that we have to get engaged with whether it's a contact or a health worker and inform them all what we know and what are the benefits. In actual fact, when we did that in the last Ebola vaccination in Kasese and that region, we ended up requiring more vaccines than we anticipated among health workers. We were not able to fully address the demand of the health workers in the west of Uganda when the vaccine was deployed. But that doesn't mean hesitancy does not exist. It's all a point of communicating and making every person taking the vaccine know all the details we know. What are the benefits? Well, what are the potential side effects, minor or major? So, and also what are the benefits for the community? And if we do that, I'm sure we would not have as much hesitancy as in COVID. But the very fact that Ebola is deadly, it also makes it relatively easier to make a case why people need the vaccine, why the contacts need the vaccine, why the health workers need the vaccine. Thank you.
If I may add something, I think this is not the first time for an Ebola virus to be tried out, even as we are rolling it out. And it's important for our communication, not only with the community, but with our colleagues, the health workers, to tell them this. This is what led to the success in the Ebola Zaire virus, the vaccines that have been developed. It was with using the vaccine at the same time as monitoring very carefully its effectiveness, the risks of this vaccine. That's how we made progress in this Ebola vaccines that are being used in the other outbreaks. And I'd just like to add also that, of course, we need to communicate with our colleagues, build their trust, communicate with the communities as well, so that we help people understand the unique opportunity that exists, even if it's a very difficult situation, to develop an effective vaccine, which in the future we can just roll out when we have cases of Ebola. Hopefully, we'll plan, and we are starting already our communication with our colleagues so that we get their cooperation and understanding. Thanks.
Thank you, Dr.
And here, I would like to emphasize, you are our messengers. So you communicating this benefit for the contacts and to stop this outbreak and to build the evidence is important. Because our biggest enemy is not only the virus, it's the false information. Thank you.
Thank you, Dr. Jonas, for the addition as well.
I think you raise a good question. But you do recall 2 years ago when we had all the misinformation about the COVID vaccines, how they were going to be dangerous, and that came to pass. So we sometimes expect that, but the most important thing is, as WR has said, is appreciating the risk and knowing that the deployment of these molecules, they are safe and because they've tested before they actually come to humans. And we are sure that people are safe. And of course, not to play in hands of people who say that, as we saw in COVID, about the COVID vaccines that are unsafe, but this came to pass that they were safe molecules. As we are, all of us are being vaccinated with the COVID vaccines, and we are still safe. And I think.
Thank you
very much,
Dr. Mary, we have Dr. Moiti, which has another engagement. Maybe you can give her the mic to say her final words before leaving, please.
Yeah, so we are coming to the end of the presser. Dr. Moiti, we can start with you. Your final thoughts on for today.
Okay, thank you very much, Mary. First of all, I'd like to thank very much Lieutenant Colonel Henry for having joined us and commend you for the work that you are doing as the leader of the incident management process. Also thank Dr. Jonas, our WHO representative, and really thank all the responders to this Ebola outbreak in Uganda. It was my privilege to visit in the field yesterday with Honorable Minister and some partners, and we really met some amazing, committed, dedicated colleagues who are working day and night to bring this outbreak to a close. So I can only say through you, colleagues, that all our encouragement to them, and thank you to the leadership of the country for putting such an emphasis on bringing this to a close. Because as we said many times, it's for the benefit, of course, of the people of Uganda, the people who are infected, particularly in the districts and areas where this has taken root, but it's also in the interest of all of us in the neighboring countries, in the region, and internationally to bring this outbreak to a close, so that we, as an outbreak of Ebola, which came upon us as we were emerging from the COVID-19 pandemic, does not just add to the impact of that pandemic. And then finally, as we always say, to the communities that are directly affected, thank them for their cooperation with the measures that are being put in place, because their role is absolutely central to our collective success. So those people that we met as well, we saw patients, their families coming to visit them. Their role is absolutely central to our success. So to the community leaders as well, please let's work together to support people to cooperate with this work. It's very urgent that it happens and we recover from this twin pandemics or epidemic and a pandemic that are affecting Uganda and potentially threatening the rest of the world. As for the other themes of today, I can only add that non-communicable diseases are emerging as soon going to be overtaking, and in some parts of our continent have already overtaken communicable diseases as the #1 killers. So issues like diabetes deserve our attention, as well as we are working as WHO to carry out various measures, sensitize governments, sensitize partners to support action on these, as well as on communicable diseases, and most importantly, sensitize communities so that we also play our role in preventing the non-communicable diseases in our region. Thank you very much. And to our colleagues, the journalists, please continue to spread the word. We thank you for the work that you are doing in disseminating information about public health diseases, and very importantly, this Ebola outbreak in Uganda. Thank you.
Thank you very much, Dr. Moeti, and thanks so much for joining us from Uganda despite your mission. Let me turn over to Dr. Jonas for your final thoughts, and then Dr. Henry Kobe.
I think I have only one message, and that's to the journalists. Help us communicate the right messages. And also help, when you are in doubt, please come to us so that we verify the information. When we don't know, we don't know. But when we know, we would like you to know the same facts so that we communicate with the community the right things. You are our heroes to communicate the public. Thank you.
Thank you very much, Dr. Jonas, and over to you, Lieutenant Colonel Dr. Bosa, please.
Thank you so much, Mary. There's an African saying that when your house is on fire, you only realize your friends when they turn up to be with you. Dr. Moet, we thank you for coming around. We thank you for taking the courage to go into the epicenter and directly interacting with the people who are directly affected. So we commend that and we thank you. We also thank you and the entire WHO machinery, and of course the UN family, and all partners who are supporting us and who have supported us from the very beginning. We are in a phase which is complex. We are still holding on to the original epicenter, but having cases moving to the urban setting, very complex setting, knowing that most of the measures for control of Ebola were designed based on rural settings. They were not designed for urban settings. That's why it becomes quite complex to do contact tracing in an urban setting, where one individual can have several contacts, unlike in the rural setting. And again, we don't have newer public health tools to be able to deal with this. But we hope, and we're very hopeful with the population working with us, that we shall be able to bring this outbreak to a speedy end with minimal effects to the people's lives and the minimal loss of lives. Again, I thank you, colleagues, journalists, for spreading the information. We're glad we've not had a lot of misinformation, and we pray this goes ahead. And as WR said, that whenever you need additional information, reach us. We'll be able to provide this to you so that we communicate to the best information to the population. Again, thank you so much, Dr. Moeti, and welcome back to Uganda anytime soon. I hope it'll be soon when we will end this outbreak. Thank you.
I'll be back to celebrate.
Thanks. Thank you very much, Lieutenant Colonel Dr. Bosa. And on that note, as Dr. Moeti rightly said, we will be back to celebrate the end of Ebola in Uganda. So I would like to say a very big thank you to all our panelists, and thanks to all the journalists and our interpreters, everyone, the communications team, the team from Uganda. Thank you so much, and I wish you a great day. And let's celebrate the Antimicrobial Week. Let's try to pass the information to reduce antimicrobial resistance. Thank you, and have a nice day.
Thank you. Thank you very much for having joined us.
I couldn't make it.
Sometimes we forget that because it is so great.